To our first North East London educational session. We are very, very lucky to have Nick Kay, the Chief Nurse at BHRUT, to do our first presentation. And she will say that for herself, how much inspiration she is in cancer nursing and her background, and I'll leave that for her to talk about. Just a few ground rules. We will be working, we will finish bang on 10 o'clock. To get your certificate of attendance, you need to fill it in.
You're on mute, or it's me, I can't hear you. It might
Can
be
anyone
my
else?
computer.
I can hear Kate.
I can hear you.
Okay.
I can hear.
Okay, it's just I can hear you now. It might be just mine, sorry.
Okay.
It's fixed now.
Yes. So just for your certificates of attendance, if you complete the survey at the end, it is a quick survey. It will ask your email address, and you automatically will get a certificate for attendance sent to you. Like I said, Nick, I was just saying, you've got an amazing career in cancer, and you've worked your way all the way up to Chief Nursing Officer, and I'll let you explain how you've got there. And what we're going to do is do questions at the end in the last 15 minutes. If you can ask questions and put your hand up for questions, or if you want to put them in the chat, you don't feel confident to put your hand up and ask questions, you can put them in the chat and we'll ask those questions for you. Okay, I'm going to leave you to Nick to carry on the session. Thank you.
Oh, thank you, Kate. So I'm the first one to do one of these sessions, so I hope you enjoy it. And as Kate has rightly said, it'd be really good once I finish my few slides to ask me any questions you want. There's quite a mixed audience here today, so trying to get slides that kind of hit the mark for everybody has been a little bit challenging, I must say. So if there's something I don't cover that you would really like to know, or you would like to know more about, then really do please put your hand up and ask me. I'm more than willing to answer any questions. What I'm hoping for is that you can see by the end of this session that working within cancer care gives you tremendous opportunities and allows you to work with the very best of teams, and also to be able to influence the care that patients receive in the future as well. So hopefully you'll see that. So as you say, I'm Chief Nurse at BHRUT, and I've been here for 6 months. And prior to being Chief Nurse at BHRUT, I was a Chief Nurse in Kingston and Richmond for 4 years. And it was quite unusual when I was at Kingston and Richmond, because actually cancer remained in my portfolio, because I've always been so passionate about cancer care that it seemed to just stay with me through my journey. And even at BHRUT, I'm very keen to work very closely with Lizzie and the team. Now my slide doesn't seem to be moving on. You might need to bear with me 1 second. I've got a technical it. Got my lovely assistant coming to join me. Okay. So I thought I'd start right at the beginning. So I trained, as you would tell, I'm Scottish, and I trained in Lanarkshire in Scotland back in 1994. And this picture is actually the hospital I trained in. It's an old psychiatric hospital in Lanarkshire. I was the second cohort of Project 2000, and the reason for sharing that with you is that was a really challenging time to come into nursing, because that's when the move was to move to more of an academic aspect of nursing and move away from student nurses being included in the numbers. So I wasn't always met with the happiness of smiles when I reached my clinical areas, but again, those challenges set you up for the future. And I got my first staff nurse job in the Beatson Oncology Centre in Glasgow. Now, the reason for sharing this with you as well was at that time, and some of you may still experience this, that as a newly qualified nurse, you weren't able to work within cancer care. So what the advert said is you had to have a minimum of 6 months experience in either medicine or surgery. But I'm quite determined, and those of you on the call who know me know that I don't accept no. So I actually wrote to the head of nursing for cancer in the Beatson as a student nurse, and I popped all my hard drive discs of all my assignments that I'd written about cancer nursing into the envelope. And she rang me up and said, would I come for a meeting? It wasn't an interview. And she said, nobody had ever done that before. And I said, well, I'm really, really keen to be a cancer nurse. And she talked me through why cancer nursing wasn't the ideal place for a newly qualified nurse. But by the end of the conversation, I'd managed to convince her to give me a go. And I had an interview, and I was successful to be one of the very first newly qualified nurses to work in the Beatson Oncology Centre. So I worked there for a couple of years. I did a mixture of ward experience, because they had a rotation programme there. And I worked with teenage and young adults, a radiotherapy ward, breast cancer, and haematology. But then because I had my diploma, I wanted to get my degree, and I saw an advert in the Nursing Times to come down to London and start the course at the Royal Marsden. I arrived in 1999 and had a plan that I was going to work my way back up the country. I was going to go to Leeds and work in Jimmy's because I used to watch that on TV. Then I was going to go back and take another job in Glasgow. But as you will work out, I never ever returned, and I've been in London ever since. So I graduated and I got a degree in cancer nursing, and then I was working on the wards, and I didn't quite know what my next step was, because the natural progression is to be a ward manager and then move into either be a matron or a more specialist role. But I didn't want to be a ward manager. I don't know, I didn't want to be a manager at all, to be honest. And I thought, how can I find another route? And then I was really fortunate. I was out for dinner one evening and one of my friends said, have you seen the advert for a specialist sister in gynae oncology? And it was a band 7. And it was to work within a clinical nurse specialist team. So I applied for the job and I was successful. And I loved it, absolutely loved it. I really loved the autonomy of the specialist role. I loved the patients that I met, the families, providing care to patients at end of life and as they embarked on their journey through cancer treatment. I worked with very special teams, and working at the Marsden is such a great place. And then the politics kicked in. I had done the job for, as you can see, 3 years. I was a band 7, but they wouldn't call me a clinical nurse specialist. So I didn't know why. So I spoke to my line manager and they said, it's because you've not got a master's. And I thought, what does a master's do to me? It's going to keep me at the same band. Why do I want to go and study a master's? Anyway, I met with the chief nurse and he said to me, Nick, I think you've got an inspiring career ahead of you. You really need to do a master's. You really need to go and do it. And I said, okay, I will do one in cancer nursing. And he said, no. You've got a degree in cancer nursing, you've got enough experience in cancer, you need to do something different. So I went and did a bit of research and came across the Advanced Nursing Practice Masters at King's College. And I thought, oh, I don't want to be an AMP. And then I chatted again with some colleagues and friends. And then I decided actually I'd give it a go. And then out of principle, when I started the Masters, they retitled me Clinical Nurse Specialist. And the reason for sharing that is there are always politics along the way, but you just have to persevere. And sometimes the advice you get is actually career changing. Now, those of you who are on the call, and I see lots of familiar faces, will know one of the things I'm most passionate about is patient care. And that's why I enjoyed being a clinical nurse specialist. But one of the things I often observe is the clinical nurse specialist voice is not always heard within the MDT. And there was one MDT that there was a particular case discussed when I was a clinical nurse specialist. And it was a young woman who had presented to ED with bleeding when she was 18 weeks pregnant with twins. She'd gone through various diagnostics and it turned out that she had stage 1 cervical cancer. And the treatment for her was a radical hysterectomy. And I remember that MDT discussion because we were talking about how we were going to terminate the twins. We were talking about doing the hysterectomy at the same time. We were having lots of discussions. And what it showed me in that MDT is everybody brings an opinion and everybody brings a view. But in talking to the patient, who doesn't mind me mentioning her name, first name Michelle, and her husband, she was really conflicted. She was Catholic. She had one child already who she wanted to live for, but equally she didn't believe in termination. She asked me if she could come to the MDT with me, and I explained that the MDT didn't allow patients to come. And then she went off, and the next day she phoned me and she said, could I read a letter to the MDT? And she was very intelligent, the woman, and she asked questions of the MDT that provoked curiosity, made the team feel slightly different. She asked a question like, by the time I have my hysterectomy, I'll be 25 weeks pregnant. My babies will be viable. Can they be delivered? And through reading that letter, the MDT started to think about her care requirements in a different way. And that's not being disrespectful to my colleagues. It's just to show the power of actually having the patient voice in an MDT. But also what I found was my voice and how important my voice was in influencing the care of our patients. So what I would say to my clinical nurse specialist colleagues, please make sure you find your voice in the MDT. We are really just as valuable as any other member in the team. Michelle went on and had her twins, 2 girls, and they're now 17 years old. She survived her cervical cancer, and is the mum of 3 children. So then I had to make a decision. I'd been a clinical nurse specialist, loved it, loved the patient contact, didn't have a lot of management experience, and I could see that jobs for the future, you needed to have management experience. So there was a job advertised at Barts Health, which was Barts at the time, for a lead clinical nurse specialist to manage a team of CNSs. So I saw this as an ideal opportunity to get my management experience. So I started in 2008 in Barts Hospital as the lead CNS for gynae oncology. And I had an amazing time, because the other thing after being at the Marsden for 10 years is I didn't appreciate that cancer care could just be as good in any other setting. So coming to Barts was actually incredible, and I know some of you who are on the call worked with me at Barts, and it's lovely to see some very friendly faces. It was through my time at Barts that I managed to progress my career. So I started as lead cancer nurse, a lead nurse for gynae oncology, and then soon I was the lead nurse for women's cancer, which included breast. And then towards the end of my time at Barts, I was promoted to the lead nurse for solid cancer. But when I was at Barts, that's when I worked as an advanced nurse practitioner. I worked within the cancer setting of oncology clinics, chemotherapy clinics. So I used to see patients who were on treatment, a cycle 2 and 4, and I used to run an on-treatment chemotherapy clinic as well. Being a nurse practitioner is quite challenging as well, because I worked with some clinicians where, traditional models of medical care were there. So I had to influence and use my influencing skills. I used to sneak away some notes of patients that I felt I could see that the consultant thought he could see. And we now have a wonderful friendship and actually joke about the times his notes disappeared in his clinic. But there's a great space to be an advanced nurse practitioner within cancer care as well. And then I moved to Kingston Hospital to be the lead cancer nurse. And it was at this point that I recognised that being a cancer nurse actually gives you so much experience. You work in surgery, you can work in medicine, you see patients that come through ED, you see patients at the end of your life, and actually being a cancer nurse gives you a whole holistic view. So I started in Kingston as a lead cancer nurse, and I just want to share a couple of stories around that. So one of the things that was put into my portfolio, which is very unusual, and I must say very unusual if not unique, was cancer performance. So when I arrived at Kingston, we were failing 4 of the constitutional standards. And the chief executive at the time said to me, what did I think? And I said, well, I can see the problem. There's a disconnect with the performance targets and the patients. So what I did was took away the stick and I brought out the carrot, and I used the advanced communication skills of nurses to work closely with my multidisciplinary colleagues and my GP colleagues as well to turn around cancer performance. And I did that by reminding everybody that the number of people on the tracker were actually people, they were individuals, they had families, they wanted positive outcomes, and they wanted their treatment as fast as possible. I also started to be an active member of the performance meetings, and therefore early identified patients with cancer and ensured that they went first for any diagnostics. I worked really closely with my GP colleagues to ensure that the referrals that came in were of good quality, which meant we could do triage and move patients straight to test. And I'm really proud of this achievement, because working as a team to achieve this was quite a significant part of my career, and it did make a difference to patients. Again, I often hear clinical nurse specialists or some of my consultant colleagues say, performance isn't our thing, we're not responsible, that's an ops thing. But I'd urge each and every one of you on the call to remember that these are patients, and if we can add value to that journey, then we should add it at each and every part. So success was had, and I was delighted. So in one of the pictures, I got runner-up, or the lead team got runner-up, but the MDT coordinators won the prize. And working really closely with the MDT coordinators, they actually are incredible at what they do, and they know exactly where patients are on their journey, and becoming their friends and close colleague and respecting their job helped me deliver in what I needed to do. I've talked a little bit about advanced clinical practice, and this is something that I'm really passionate about, because if you always do what you've always done, you'll always get what you've always got. And teams should look different now. We should anticipate and provide care in different models, working closely with our colleagues. And this is a couple of success stories I've had. When I was at Barts, I started stratified follow-up in breast and colorectal cancer, and it was nurse-led. And then when I moved to Kingston, I developed a skin cancer-led pathway, nurse-led pathway. And this is a picture of my lovely colleague, Alberto, who, when I started working with him, was doing skin biopsies. And when I left him 6 months ago, is now able to actually operate on patients and do skin flaps. And he's one of the few nurses in the country that can do that. So again, the art of the possible, and you have to believe in it. And he can only achieve that, and I could only achieve that as his line manager, by working really closely with my colleagues. I've also been involved in setting up nurse-led nasal endoscopy service, a nurse-led nodule service, and I've also developed a number of ACPs along my way. But I haven't done any of this without working closely with my medical colleagues and my colleagues in primary care. Collaboration is key. Now, I just wanted to flag something, and those of you who know me on this call will know this. I am a massive introvert, and often I meet nurses who say, I couldn't be a chief nurse, I couldn't be a lead cancer nurse, I couldn't be an AMP. I often used to look at people in meetings and think, oh, I wish I could stand at the front and be as confident as them. I wish I could speak at that meeting. But there is a space at the table for introverts. And introverts have a very different leadership style, but that doesn't mean it's better or worse than other people. And I just wanted to share that because actually within cancer care, it's allowed me as a massive introvert to develop and become a chief nurse. So I just want to encourage those on the call who think it's not possible. It is. There's a space at the table for us all. And I'm nearly finished. A couple more points. The other thing I've learned as well is in teams, it's important to work with different personality types. And one of the things that I find most useful is often looking at people's Myers-Briggs and their preference. Because if there's a problem or a challenge or a bottleneck, often working out how your colleagues work is the best way to get round and find a solution. When I was interviewed for the post of chief nurse at Kingston and Richmond, I was asked for 3 words to describe myself. Now, you'll notice on these, of those nurses and doctors and colleagues who were around in COVID times, that this is PPE, and that was the name, that's the way I could remember it. But I'm purposeful. When I set out to do something, I know exactly what I want to achieve. I'm very persuasive. I've actually managed to get clinic rooms built in a waiting room by taking the States team on a walkabout, and the next thing they knew, there was tape on the floor and clinic rooms going up. And I'm very encouraging of others. It's not for me about what I achieve. It's about what others achieve. And the other thing I should say that's really important to me as I move through my career, I remember thinking, I don't want to move away from patient contact. But actually what I've learned as I've gone through my career is that if you're able to influence, which you can as a senior leader, that has the biggest impact on patient care. And also if you're able to encourage your colleagues, that also means that patients receive the best care possible. I hope I've touched on this a lot because one of the things that's really important to me is multi-professional team working and recognising everybody has a skill to bring, and that means working together to deliver the best care for patients, taking down some of the bureaucracy that exists within professional groups and actually just working together, whether it be through primary care, acute, community, hospice care. And the other thing I'd encourage and urge you to do, these are difficult times in the NHS, there's lots of conversations around money. Have fun, enjoy what you do, and don't be afraid to take a risk every now and then. As I said before, if you always do what you've always done, you always get what you've always got. Anticipate where cancer care is going and be ready to take the next step. And this is my final slide, you'll be relieved. And this is a picture of my daughter. I love being a nurse. I'm not trying to really influence her, but if she was a nurse, I'd be incredibly proud. I think it's an incredibly good career. You get to meet many, many different people and you get to touch people's lives. And that is the absolute delight I've had of being a cancer nurse. And this is going back to the Myers-Briggs. And this was written in my leaving card when I left Kingston. And I think it's so true that my style excels in fields that deal with possibilities for people. That's one of the things that I'm most proud of when I look back. And for any of you on the call who would like to come and spend any time with me or to work alongside me or to, just meet me, then you're more than welcome because I'm more than happy to encourage you. Thank you. Kate.
Thank you. Hi, thank you, Nick. That was amazing. And I hope that's inspired so many people to do more things in their career and to take things forward. I'm aware that we have got a few community nurses on the call, and I just wondered if they were sort of looking to change direction from the community into a cancer post. What would your advice be to them?
Thank you, Kate. Well, I've actually experienced that because when I was at Kingston and Richmond, I used to manage cancer services, community services, and there's a couple of nurses that I've worked with who've wanted to progress into cancer care. I mean, I think there is a role for community nurses in cancer care, which again is in the future as well, that could be delivered. But I would definitely encourage them to do their cancer course and definitely spend some time within a cancer setting.
Lovely. Now, just opening door. Anybody you got any questions for Nick?
Please do.
Yeah, I think we've got some comments in there that said that you're such an inspiration, Nick, and there are someone was also said about there are a lot of echoes of thoughts that had careersmen, the moves they've done, and really inspiring as well. So I think that's really thing. And I think you mentioned in your presentation about the power of the voice in MDT, and I know as the CDL for North East London, speaking to lots of nurses, this is a huge challenge at the moment, more so than ever. Is there any way that they can build their confidence in that, being the nursing voice, do you think, and how they could do that?
I think it comes back to the team that you work in as well, Kate, and how colleagues can help bring you in and make sure that they invite you. Because one of the things I often say, going back to being an introvert, is I do often tell a couple of colleagues that my style might not be to put my hand up and speak, but please ask me. So one of the things I would say to people, if anybody felt like their voice wasn't heard enough, is actually confide in a colleague, who either the chair of the MDT, and say to them, could you invite me in sometimes? And sometimes that's an easier way to contribute to the discussion. But I would also remember that your role in the MDT is to be the voice of the patient. And I think if you step outside of your clinical nurse specialist role a little bit and remind yourself why you're there and why it's important. And that doesn't mean talking for every patient, but it means where there's complex discussion, is ensuring that you step into that space. So I do a combination of things. I'll either ask a colleague to invite me in advance. So if I know there's something that's going to be a little bit tricky, I might say before the meeting, and I did actually before that MDT as well, I said to the chair of the MDT, the patient has given me a letter she wants me to read, can you invite me in? So that can be a good way, because often you've got the MDT list in advance of the MDT, so you kind of know the patients that you want to contribute to. One of the other things I forgot to mention actually on the BART slide that I had to do, which, oh gosh, really challenged me, is I was actually on the chair of the MDT rota with the consultants because I was the lead nurse. And I had never chaired an MDT before. And that was quite a different experience, and a privilege actually, because it gained a lot of insight into how difficult it actually is to chair an MDT. But actually to have that respect of my colleagues to trust me to be able to do so was really, really good as well.
Hi, Sarita, do you want to ask your question?
Hi, yes, thank you so much, Nick. Honestly, that was just so powerful and so inspiring. I just want to thank you so much for talking to us today.
No, I can't hear you. It might be my speaker again.
Oh,
sorry.
Can anybody else hear me?
Yes.
Yeah. Oh, sorry,
Yeah,
Nick.
I can hear you.
Brilliant, thank you.
Okay. It might be my computer. Myself and other Alliance colleagues on this call I'm non-clinical, I'm not a nurse, I am a program manager, so apologies for that, but I just wanted to say that we are massive advocates for our nursing colleagues, so that's one of the reasons why we're kind of here today. Nick, I just wondered, have you seen any examples where any MDTs might be co-chaired between, kind of like doctor, medical, and perhaps a nursing or an AHP voice? And I was wondering if that might be something that we can start to push for, again, to kind of give that voice to our communities.
I think that's a brilliant idea. So I don't know of anywhere that's doing that. I think they remain very traditional in terms of the approach to the MDT, but I absolutely think that would be a great idea. And I know at various points in my career, people have talked about having patients come to the MDT. And again, because of the time constraints, people have been very anti that. But I think a co-chair model will help to get that holistic approach, because ultimately cancer is a holistic thing. So I think that would definitely, I think that would be brilliant. I would definitely encourage that.
I think I just
And
heard
actually, it will
someone.
help the nurses build their confidence. And I think some of it's about confidence as well. And again, as you step into more senior roles, that can be kind of tricky territory. So I think having a model like that would actually be quite attractive.
I'm the chair of my MDT. I'm a nurse.
Thanks, Sam. Yeah. Sam works at Bart's in urology, so she's the lead nurse. So yeah. Oh, that's good to hear, Sam. So you could tell everybody how to do that. Yes. Yeah.
I absolutely agree with you, Nick. It's paramount.
That's brilliant,
that
Sam. I'm
are,
really impressed. And you will know that is not easy to do.
It's probably one of the hardest positions, even as the lead nurse that I have here at Bart's. That, mind you, it's not paid and it's not job planned. I do it because nurses need to have a seat at the table, and so I completely agree. Nick, your story is so inspiring. So thank you.
Oh, thank you. That's kind.
We go to Catherine.
Now, Catherine, I can't hear you.
Yeah.
Sorry.
Yeah, I think you're still on mute, Catherine.
That's
Is that
it.
better?
Nope.
Can you hear me okay?
Yes, lovely, thank you.
Can everyone else hear Catherine?
Yes, we can.
Yeah, I can.
Sorry.
Yes, yeah.
It was me that put there was
Oh,
lots of
my speakers are bizarre today.
there was lots of echoes. It might be because I'm on headphones as well. I'm not sure. Sorry. I was just going to say, yeah, whenever you said, oh, I just wanted to stay clinical, I didn't really want to manage, I just to stay patient facing. Like, I've had all of those thoughts and conversations with, my line manager. My line manager said, to think about kind of leads and heads in the future, and I'm kind of like, I'm happy where I am. So yeah, you gave me a lot of so.
Kate, are you able to tell me what the question was? Sorry, because I couldn't hear.
I think Catherine was just reiterating that you've inspired her as an AMP and the thoughts of how she could move forward and where she goes, but she wanted to stay patient facing. So yeah, is that correct, Catherine? Sorry. Yeah. Yeah. Okay.
Yeah, and that is one of the biggest challenges. I remember as I was moving out of being patient facing, really thinking long and hard about it. And it was, and to be honest with you, even when I was at Kingston, I haven't done it so much at BHRUT, I'll often stray and find myself back in a cancer clinic or a waiting room talking to people, because it is difficult to move away from dealing with patients. It is rewarding.
And then I think we've got Marissa.
Thank you so much, Kate, and thank you, Nick, for the amazing presentation, and congratulations for such an incredible career. Can you hear me okay? Yeah. So my question was around so more because I'm so inspired by you, but how difficult was it to make the decision? Because such as probably Catherine, so I was an AMP before, and now I moved into a lead nurse role, and I can see just my role keeps expanding. I also chair the MDT every 4 weeks, so we do a rotation with all the consultants, so I'm part of the consultant rotation. And I agree, at times it's difficult to have a voice in the MDT, especially as a nurse, so it's difficult to, find your
Just getting
seat.
my assistant again, because I can't hear. Kate, you seem to be the only one I can hear.
Oh, that's weird. I don't know what's happening.
Can you hear me, Nick?
Yeah.
Can you hear me?
I can hear everybody.
I can hear everybody.
Well, I can hear you now, but I don't know. I couldn't hear Marissa, and I couldn't hear. Marissa, will you try again?
Yeah, sure. So to start with, Nick, I just wanted to say thank you for your presentation and congratulations for such a career. Can you hear me? No? No, I don't think she can hear me.
Okay. So far, Marissa's saying to you, Nick, congratulations on your career and your amazing presentation.
And I just basically wanted to ask her how difficult was it to make the transition and then step away from clinical, because I think she's already resonated some of the answer in the previous in the previous question by Catherine, I think. But if she was not to be in this current role,
okay, Kate. Well, when I hear people, I'll tell you. If I don't hear, then You just need to let me know what the questions are. We can't seem to work out what the computer issue is, but I can hear some of you and not others. So sorry.
That's weird, isn't it? Yeah.
So I just wanted to basically find out if she was not to be in her current role, if she was to stay in a clinical role, what would that be? And for example, I would not see myself in her role in the future, because that's not where, because I do not want to move away from clinical. I always want to have clinical as part of my role. What would she aspire that it would have been the role that she'll be in if she stayed clinical? Sorry, Kate, is it a difficult thing to translate, probably?
No, I think I've got that, Marissa. Okay.
Thank you.
So Marissa was saying, obviously about your amazing career and how difficult was it for you to actually make that transition into that role and for you to take that forward. But if you hadn't have done that and you wanted to stay clinical, where would you have gone to next in your role?
Okay, I think where I'd go to next is probably where I want to go when I retire. I think I'd go back to being a clinical nurse specialist. And I think I know I'd really like to do end of life care. I'd like to do palliative care. That's what I'd like to do. I really enjoyed, as much as I enjoyed being an AMP, I particularly enjoyed being a clinical nurse specialist and really providing care to patients. And again, I was probably more drawn to the people because with ovarian cancer, a lot of stage 3, 4, I was drawn to kind of end of life care. So I probably would go palliative care.
Thank you.
We've got one in the chat, so I'll come to that and then I'll come to you, Yvonne. Okay.
Well, the other thing, Kate, I forgot to say about the transition into the role. I found it remarkably seamless, if I'm completely honest, because that's where I was a bit naive. I used to think, well, I'm a cancer nurse. I can't possibly do general nursing and be in general meetings. And it was actually when I stepped into being Deputy Director of Nursing, just as a bit of a secondment, that I recognised that actually I did know a bit about surgery and theatres, and I did know a bit about coming into ED, and I did know a bit about outpatients, and I did know a bit about ITU, because I do think the patients we look after go through so many different groups, and again, GPs and working with primary care. So it actually was easier than I thought, because the skills are quite transferable.
Yeah, and
it's not, but I should say, sorry, Kate, I should say it's not an easy job when but the transition wasn't too hard.
Yeah, I know what you're saying. Since I've changed into this role, I find that you do understand bits and pieces of things that you've never done. I'm going to come to one in the chat and then come to Yvonne. So Jennifer Connor sort of put that district nurses provide all the community palliative care within the health trust, along with support from our local hospice who have regular MDTs with. It'd be really useful to be included in the MDTs with our local hospitals when they are discharging patients home. Do you have any suggestions as how this could be set up? We find the discharge at this point when continued care can be really a real breakdown. So that's quite a difficult one for you to answer, Nick.
Yeah, but I also think it's a good one, because I think people forget that specialist palliative care deals with kind of end-of-life care for patients that've got complex end-of-life care needs. And we forget about the patients who go home and have end-of-life care is provided by the district nurses. And actually, if you look at the proportion, it's actually greater than those who have Macmillan support. So actually, community nurses have a key role in end-of-life care. I think an MDT would be really, really good, because as the community nurses in the call will know, patients often bounce in and out of hospital before they get to that point of being right at end of life, and they've known their community nurse for a period of time and built a relationship. So again, what I would be encouraging is to connect with a clinical nurse specialist for the specialist area and look at how you can get some kind of MDT set up. So I'd be using the clinical nurse specialist to start to have that conversation and how that can help. And it's also important for GPs to be involved as well.
And
I think it's good.
Yeah, and I wonder whether it's the Cancer Alliance, I've got Sarita and Yvonne on the call, that there may be something they can think of that we can help that transition as well, to look at that for the future. Yeah.
I think it's good. And like I was saying, we shouldn't do what we've always done. You've got to anticipate what the future is. And we've got to start look at how we develop services that are fit for the future, so they're cost effective as well. And I think it's working closer with colleagues, as I say, is actually the secret of that success. So I think anything that can be done to strengthen relationships and cross boundaries is the best thing for patients.
Thank you, Nick. I hope that helps you, Jennifer. Yes, she said thank you in the chat. But Jennifer, if you do want any information on that, we can certainly talk about this outside this call, and you can contact us. Okay. And Yvonne.
Thanks, Kate, and thank you so much, Nick. It's been great to hear more from you today. As Kate said, I'm also work for the Cancer Alliance. I'm one of the programme managers there, so not clinical by background, not a nurse. Again, apologies, but super interesting and lots of work that we do with our nursing and AHP colleagues. I'm going to continue the theme, really, I think, from what Jennifer was asking, but from a kind of strategy perspective. So we've had the 10-year plan this year, and I wondered what your views were around the kind of opportunities and the most impactful shifts in cancer care that the 10-year plan kind of presents, thinking about the kind of prevention, acute to community and analog to digital, and in particular that acute to community shift, and what opportunities you see. Where do you think their impact can be had within our community and primary care settings, and the role of primary community care for the care that's provided, the cancer care that's provided to patients? I'd be interested in your views on that. I'm wondering if Nicola can hear me.
You need to tell me what the question was. Sorry, so sorry.
Okay, so Yvonne, just go through it with me again. Yes, because it's quite a long one.
Yes, sorry. So it was about the 10-year plan and the three main shifts in the 10-year plan that I'm sure Nick's familiar with. So I wondered about the opportunities within that for cancer, and specifically the role of our primary and community care colleagues for working with cancer patients and supporting cancer patients.
Okay, lovely. Okay, Nick. So what Yvonne was asking, in view of the 10-year plan and obviously the shifts, what opportunities would we have in cancer within the PCT for working, and what's your thoughts on this?
Gosh, that's a good question. Very strategic. Well, I mean, the 10-year plan gives us lots of opportunity, doesn't it, to make the shift and really develop community services. So I must admit that was the bit that I was really impressed to see. So I think there are more things that we can do within community care, and I also think there are more things that we can do working closer with GPs. One of the things that I think we do too much of is follow-up, and I know I've talked a little bit about stratified follow-up, but there is further we could go if we work closer with colleagues in the community and PCT around cancer follow-up. And also there is more I think we could do around prevention, which is really, really important. And really looking at uptake with patients in terms of cervical screening, breast screening, prostate screening, looking at more we can do. But I also think talking a little bit more about those advanced practice roles where there could be roles that kind of straddle community and acute. And in the 10-year plan, it does talk about developing more ANPs, ACPs. And although I've talked a lot about nursing, I'm very proactive around my AHP colleagues, and I think there's a space for them also. So yeah, I think we could do more one-stops in the community. I think we could do more prevention work, and I think there's a greater opportunity to cross boundaries in terms of ACP. But we have to be willing to deliver care differently, and that goes back to me saying about the appetite. You need to encourage that culture within your teams to have that appetite. And I do think, and I hope some of you will agree with this, we still work too much in silos, professional silos, rather than actually recognising the skills of our colleagues and how they can be beneficial. And it's like Sarita when she introduced herself as being a non-nurse type thing, but her role is really, really important. And actually without Sarita's role, sometimes we can't do the things that we want to do. So it's just taking that time to acknowledge different people's qualities and skill sets.
Thank you. Has anybody got any other questions? Any burning questions for Nick?
Please don't be shy. I like questions, although we're having to do it in a bit of a hybrid fashion.
We haven't got any more at the moment, but as Nick was saying earlier, and I was talking to her in the week, if you do want to spend time with Nick or shadow her or see how her role is, please feel free to contact, because she's very open to that. Or even if we are doing these sessions every 2 months, and we're doing quite a lot of different sessions, and there may be things like the Cancer Alliance that you want to come and shadow and see what they do. Please feel this is about your education. It's about trying to bring everybody together in North East London, and also embrace our community college colleagues as well as our sort of like our hospital colleagues together. So it's a time where we can all meet together and collaborate. So
yeah, the other thing I would say on that, if there's any of the kind of AMP, ACP services that I've mentioned, I mean, one of the other things that I did when I was at Kingston is I led on the development of a nurse-led breast one-stop service. So we actually don't have any surgeons in our breast one-stop service. So there's multiple, and Alberto that I talked about, who's now doing plastic surgery as part of his advanced practice, he's very inspiring to meet, and his career and his journey. So even if it's not to meet me, if you want to get in touch with some of my colleagues that I've worked with who are doing good things, then please reach out as well. And also for my ward nurse colleagues who are on this call, if they're thinking about their next step or what they should do, then again, more than happy to have a chat.
Okay, so Catherine was just saying she's just got logged out, but she's just got back in, and she just wanted to share this Finding Your Voice in MDT, and actually, to be honest, what inspired me was what you were saying about that patient, Nick, and actually taking her letter to MDT, and that is something I'd never ever thought of doing. So that really inspired me. And actually, I wondered how many nurses have actually thought about doing that. I know we've thought about being that voice, but how powerful was that to take that letter and those patients' words into that MDT? Because sometimes we can represent the patient, but actually representing the patient isn't always what the patient's voice is, and actually reading that. And I just felt with the nurses, if you would think about doing that in the future, has anybody got any thoughts that they would do that? Because I think that's an amazing thing to do.
I think while people think about Kate, I could have given you millions of examples of people I've met, great patients I've been involved with, and families, but I must say it was game changing to watch the MDT discussion go from a radical hysterectomy, this is what we were going to do to terminate the twins, this was that, to then suddenly saying, can I just remind you, she's Roman Catholic, this goes against her wishes, she wants to be a mum to her son, she wants, so there was many things. And then what you really realise, and I did write a chapter on this case for a book that I can share with you, Kate, because it really did show that people bring their human factors to an MDT, and actually hearing some of what the patient felt reconnected with some of the clinicians in a really healthy way. It was a game changer. And Julie's got her hand up.
Morning, everybody. So my name's Julie. I'm currently the lead ACP for general surgery, but I'm soon to be the lead SACT nurse for BHR. My question for you, Nick, is given all the different sort of pathways of your career, any tips on managing imposter syndrome? If you've ever had it, of course. Maybe you haven't.
Did you hear that, Nick?
No, but thank you, Julie. But the thing with Julie is she will know the Wi-Fi BHRUT is very tricky. So I'm with somebody who'll understand my pain at the moment.
Yeah. Julie's just asked the question. Julie's one of the leads in one of the AMPs in surgical. She's also doing herself down because I know she's done huge amounts in chemotherapy and AOS previously, and she's shortly starting as the lead SAT nurse in BHR, and she's asking about imposter syndrome, Nick. And have you ever had it? So I'll leave you to answer that one.
No, Julie, that has to be, I don't mean to be bad to colleagues on the call, that has to be the best question, because when I got asked to do this session, my head said, yes, do it. My heart was like, no, I have massive imposter syndrome, massive. And very funny, Kate and I talked about it the other day because one of my really good friends I met when I first came to London to work in the Marsden, her and I both suffer from it. So we often exchange stories about it. Imposter syndrome is more common than we think. And it goes back to that slide I put up about the introvert as well. It's very easy as an introvert to have imposter syndrome. But I think being self-aware of the imposter syndrome is actually very healthy. So what I do is I do a bit of, and this sounds like, but I do a bit of affirmation. So sometimes if I'm feeling the imposter, I will write in my book, I am a good chief nurse. I am a good chief nurse. And I do this, take deep breaths, and I just tell myself that. So I think imposter syndrome is very common. You definitely wouldn't be alone. Kate suffers from it a little bit herself as well. So you will find most people have it. It's just how you learn to manage it. And it's really important to be honest with yourself about it and then develop a technique that gets you kind of over the line. And I've found in my time, that's why I shared the Myers-Briggs and the introvert slide, is understanding your personality type a little bit more and the things that bring the best out in you. Is the easiest way to overcome that. But it's really common. Even Karen Bonner, who's the chief nurse for England, or London, sorry, she was here last week and she talked about her imposter syndrome. So I think all the way up the line, imposter syndrome exists, and I'm not really sure it's something you ever get rid of. Sorry.
It's all right, Nick. When I saw that one, I thought you'd like that question. I can't read in the chat, but there's something I think Kate wanted to share, but I can't read it. I don't know whether Jess, you can decipher that in the chat.
The screenshot.
Yes, yeah.
It's the CNS.
And it goes back to, just while we do that, it goes back to that thing as well, Julie and others. I'm not really about self, although I'm the chief nurse. I very much enjoy promoting other people and then using the people around me to the biggest advantage as well. So that's the other thing you have to do, is look at the skills of the people around you and then just balance it out. I think it's an MDT workshop, and she's going to email it, Kate.
Yes, yeah. There is an MDT workshop course that we do for North East London that we advocate for nurses to attend. So yeah, and it is a great course. I agree with you, Catherine. I've attended it very late in my career when I started this job, just to find out what it was about, and it is really good because it's run by actors, and it's actually was set up by the Alliance previously, and I think doctors have been on that as well. So it is a great course. I agree with you, Catherine. Yeah.
And fun is important. So as I said, you've got to have fun. You've got to enjoy what you do. So yeah, having a laugh is very healthy.
So we've got the last few minutes. Has anybody got any burning questions or anything? I know Yvonne wants to connect with you, Nick, about meeting up with you to talk about some projects with the Alliance and how they can work with you. So I'm sure that'll be really helpful. Yeah.
Yeah, no, absolutely. I'm happy to meet with anyone. And I must say, in preparing for today, it was, as I say, quite hard to know how to get the right balance, because nobody's gone before me. But I have enjoyed reminiscing over my career, and I've enjoyed thinking about the people I've met along the way. Yeah, it's been interesting preparing for this meeting.
Okay, Sephora.
Hi, Nick. I've been supporting Kate in organising these sessions, and before we started this session, I was saying to Kate that my daughter, who's a second-year student, nursing student, she was at home today, and I said to her, please come and join this. And she has just literally said to me, Mummy, that's just so inspirational, and I'm really happy that I managed to listen to this. So thank you so much. I just wanted to share that with you.
Did you hear that one, Nick, or no?
Oh, I bet she didn't. Oh, poor thing.
So Sephora is an amazing woman who works in the Alliance that has helped me massively set these up, because this is my first time ever doing anything like this, and we've worked very closely together. But she was just saying her daughter is a second-year student nurse, and she happens to be at home today, and she's listened to your presentation because Sephora insisted that she listened to it, but she's actually found it very, very inspirational. I think it's great and if we could do this for student nurses, because I think we need to get these nurses early. And like you say, and I appreciate what you were saying, because in when I was a manager, we always used to say to nurses when they were coming into oncology, don't come straight into oncology, do something first. But there has been a shift in that, but I think nurses are encouraged to do something else. But if they really want to do cancer and that's what they want to do, why not?
Yeah, absolutely, absolutely. And I think you have to persevere. So I think the thing as well is like not to just accept no, to look at ways round things. Yeah.
Well, thank you. And there's been a lot of comments come through, Nick, on the chat, sort of what an inspiration, and and how inspiring it's been and that. So we do get, please feed in, like I said earlier, please fill in your feedback, and also you will all get certificates for attendance. And I have to say to you, Nick, this gets videoed as well, so there will be people who couldn't be on the call will listen to this at a later date as well. We might even put you on, virally, LinkedIn and everywhere.
Julie, the imposter syndrome's coming out now. Wonderful, thank you. Well, I mean, you've been a great audience. It's lovely to see you all, and it's lovely to see some familiar faces and people that I currently work with, as well as people I've worked with in the past. If I could just urge you, really, what things I would just finish with very quickly in the last minute is do anticipate the future and be brave enough to cross boundaries to do something different. Do take risks, and I don't mean dangerous risks, I mean balanced risks, but the future is in a bit of risk taking, and continue to be inclusive and collaborative with colleagues to ensure that patients get the best care and that every voice is heard.
And yeah, there's a lot of thank yous coming out, and people join the next sessions and things like that. So thank you ever so much for everybody attending. I am very conscious that you nurses are very busy at the moment and staffing levels and that, but I hope to see you all at the next sessions, and please let me know if you want to contact Nick, or you can email Nick directly, but I would suggest going through her secretary. Rather than leave, she might kill me.
But it would be lovely to see you, and those who work in the trust. I'm around today if you're about and you want to say hi. And yeah, please don't be afraid to ever contact me. And I wish you all the very best for your career, and hope you enjoy it as much as I am.
Thank you ever so much. Thank you, Nick. Thank you.
Take care.
Thank you.
Bye.
Thanks.
Thank you.
Bye. Bye.
Thank you, everyone.
Thank you.